Good morning to all my colleagues. Today I am presenting the case of a patient referred to our facility for suspected complex heart disease. The patient underwent the examination during the 17th week of pregnancy, and it is immediately noticeable as seen in a transverse scan of the chest. The heart seems to be structurally characterized by a single ventricular chamber. Therefore, the primary differential diagnostic consideration revolved around determining whether the condition was a univentricular heart or a hypoplastic left heart. A univentricular heart is a complex heart disease characterized by a single ventricular chamber, which can be morphologically right or morphologically left, to which it is connected. A rudimentary ventricle may be associated with it. The solitary observed ventricular chamber can have a double inlet, which signifies that it is clinically possible to observe two distinct atrioventricular valves, or a single inlet, that is, only one individual atrium communicates directly with the atrioventricular chamber through a single valve. This condition can present as mitral or tricuspid atresia, or it can be a common atrioventricular inlet connection, meaning both atria communicate through a single atrioventricular valve with the single ventricular chamber. In these cases, the outlet can be either normal, with a regular aorta and a regular pulmonary artery, or it may be characterized by a transposition of the great vessels. Alternatively, there could be an obstruction of one of the two outflow tracts with the possibility of visualizing a single vessel, meaning either the aorta or the pulmonary artery. Hypoplastic left heart. Instead, there is a group of complex heart diseases, all characterized by severe hypoplasia of the left-sided chambers. In the classic form, also known as the major form, it is characterized by hypoplasia of both the inlet and the outlet, meaning mitral atresia, with severe aortic coarctation, so the aorta may sometimes appear thread-like or even completely invisible. Or there is a minor form in which the mitral valve is only hypoplastic and the left ventricle is hypoplastic as well. However, it still appears to be clearly discernible during a comprehensive ultrasound evaluation. In the case currently under examination, from various detailed scans, it seemed there was a solitary common atrioventricular valve opening into the single ventricle. The visible single ventricle appears to be exhibiting the morphological characteristics of a right-sided ventricle, based primarily on the distinct presence of what appears to be the following features. The moderator band is located posteriorly in relation to what is the moderator band. From the sternum and from the single ventricle, a single large vessel appears to originate, as we will see later in the images, both in 2D and with the help of color. It seems to take on the morphology of the pulmonary artery, thus with an aorta that is not visible. From these images here, thanks to the cine loop, we are better able to reconstruct what appears to be the single atrioventricular valve, which opens into this retrosternal ventricle, which seems to be, in fact, the right one. As we can clearly see from this freeze frame, there appears to be a second atrial chamber, which is very small and is probably attributable to a left atrium, into which at least two pulmonary veins seem to enter. With the help of color Doppler, it is clearly visible as we move upwards towards what should be a section. Three vessels. The presence of this solitary vascular structure, which, let's say, is positioned and travels along the left side of the trachea, therefore following a regular course. Here we observe additional cross-sectional imaging views in which the valve still appears to be single, and what should be the left atrium, which in this specific scan is located on the right side of the image, appears to be receiving the drainage of two pulmonary veins. Moving from this scan to what is, in fact, the three-vessel view, we can also see here how a single vessel clearly emerges, even with the help of Doppler imaging, which appears to be just about to bifurcate. Here we see that the cytos is preserved because we have a fetus encephalic presentation. Breach, therefore, with the spine on the maternal left, and from the assessment of the relationship between the thoracic area and the cardiac area. There did not appear to be any signs of cardiac decompensation. By utilizing the assistance of Doppler, so the hemodynamics of the single visible triventricular valve was also more thoroughly assessed, which appeared to be completely preserved. And here we can see it clearly as well. With pulse Doppler, therefore, with an ER ratio of what should be a tricuspid valve, which is within the normal range. Precisely because of the extreme difficulty of the case, the cardiac anatomy was studied several times, both in grayscale and with the help of color Doppler. Here, once again, this vessel is observed, which seems to branch both with color Doppler. As you have seen, here it is very clearly visible in 2D. It appears that from this morphologically right ventricle, a single large artery originates, which seems to be, in fact, the pulmonary artery. From this angle, we can clearly see the lambda of this bifurcation. A post-wave Doppler ultrasound examination was also performed on this solitary large arterial vessel emerging from the ventricle, which showed a consistent and regular systolic peak waveform, indicating that the hemodynamics of the semilunar valve were also well preserved and functioning normally. Taking advantage of the favorable fetal position, further attempts were made. During the examination, moments were dedicated to studying the cardiac anatomy in order to better characterize the heart disease. Obviously, the goal was to try to make a differential diagnosis between a univentricular heart with a single inlet, because here in the various scans, the atrioventricular valve always appeared to be a single one, and that of a left heart of the major hypoplastic type, in which there was also a severe aortic coarctation that made it impossible to see, as we can see here again with the help of color Doppler, a vessel attributable to an aorta, thus on the left side. In any case, both are complex heart diseases that carry an exceptionally poor and challenging prognosis. In the case of a univentricular heart, the incidence is very rare, but the risk of aneuploidy, the syndromic risk, is actually lower compared to the scenario of a left-sided hypoplastic heart. In fact, the hypoplastic left heart in terms of incidence is more or less comparable to the univentricular heart, but it is associated with a significant risk of aneuploidy, which is 15% in the prenatal period and 3 to 4% in the postnatal period. This is because, since the diagnostic picture is associated with an extremely unfavorable prognosis, the majority of pregnancies that receive this type of diagnosis, often result in a voluntary termination of pregnancy. The syndromic risk, too, in the case of hypoplastic left heart, turns out to be somewhat higher compared to that of the univentricular heart. The aneuploidy conditions most frequently associated with this picture are Turner syndrome, trisomy 18, and trisomy 13 in order of frequency, while among the syndromic conditions we recognize charge syndrome. For both conditions, however, the outcome is exceptionally poor and unfavorable, with a significant risk of postnatal mortality even after surgical intervention. To complete the presentation of the ultrasound findings, as you can see from these images, we also point out the association of the congenital cardiac abnormality with increased intestinal echogenicity. This is very clearly and distinctly highlighted here, even when reducing the gain in grayscale. Meanwhile, when examining the cranial structures at the brain level, we can clearly observe and highlight the presence of choroid plexus cysts, which appear more prominent in the right plexus, which here is the one at the bottom, and less so, though still clearly evident, in the left plexus. Therefore, the patient was recommended to undergo an invasive examination with karyotype and RIC-GH, which in fact she had already undergone. Before our ultrasound evaluation and to complete the assessment, a pediatric cardiac surgery and cardiology consultation was also performed, mainly to gain a better understanding of what the postnatal outcome would be and indeed the prognosis of this condition. Thank you for your attention. Thank you all very much.